Good morning, everybody. Welcome to the CCG Business Workstream. I'm Amanda Doyle. I'm the chair for the session. I'm a GP in Blackpool, Chief Officer of Blackpool CCG. Couple of housekeeping things. First of all, please, can people put the mobile phones on silent? I'm quite sure no one's going to turn them off. Couple of changes to the programme which I'll point out as we go along, just changes in speakers rather than time. You've all got feedback forms on your chair. Please can you fill them in and post them in the boxes on your way out. People who want CPD hours from these sessions, if you just get yourself scanned on the way out, certificates will be emailed to you. And don't forget, tea and coffee is available at the stands outside, so just grab one when you need one. I would now like to introduce our first speaker for the session. Roughton is the fairly recently appointed Interim National Director for Commissioning Development. Prior to that, she's been working with NHS England, or within NHS England, developing relationships within the new commissioning system, responsible for strategy, I think. So I'll hand over to Ros.
Thanks, Amanda, and welcome, everybody. As Amanda said, I've been about 7 weeks into this role in NHS England, and in that role I oversee the development of the commissioning sector. And what I wanted to do today was to give you some context and backdrop to what we think the commissioning sector needs to do and how, with NHS England and partners, we hope to help build the commissioning sector to be as good as possible in delivering the outcomes we want to see. I want to begin by just setting the context, and this is where I check my technological ability. This is very kind of familiar, but I make no apologies for going over this again. I think that the NHS faces a period of very tight financial constraints for some considerable time. This isn't going to be just a one-year thing, and together with the changing demographics, which many of you will see every day in your practice, together with rising expectations, the challenge of improving outcomes so that we are among the best in the world, the challenge of tackling inequalities in that environment is going to be very tough. And the only way that we can do that will be by changing the way in which we are delivering care, changing the relationship between the individual and the system. And so for us, everything that we are trying to do in supporting the development of the commissioning sector, everything that you may be doing in your own spheres, needs to be directed not just at securing quality today, but at leading the transformation of tomorrow, making sure that we have a sustainable NHS, as a service that's free at the point of use, something which this country holds so dear, for our families, for our children, for ourselves as we get older, and that's something that is there in the future. And we need to make sure that we focus as much on the sustainability as we do on the here and now. So in terms of the work that we are beginning around how do we support the development of that, those are the two things that we're trying to hold in mind. So I'm going to give you an overview of 4 areas of work, and the first is around CCGs. I think authorisation was a kind of initial step on the way, and I hope and I feel in this conference here today that it has ignited the passion amongst many of you. Many clinicians have stepped up to take on leadership roles within their CCGs, have stepped up to take on leadership roles within their communities. And I think it's a fantastic start that we've made. We've looked at the outcomes of that authorisation process, about what did we learn across the country, all of that in-depth work at 211 CCGs, to begin to describe what characterises great CCGs that can both do that securing quality today and leading transformation tomorrow. And there are 6 things that we've come up with, and be very interested in people's comments on that. The first is a strong sense of the CCG belonging to its members. For the first time in the NHS, we've created in statute membership organisations, and I think it's really important that we don't lose sight of the strength that this can create, the dynamic it creates. So how connected are you to your CCG? How connected are you as a CCG leader or as a member of a governing body to your members is a really important question, because that will determine the success of your CCG. The second characteristic has been about being driven by insight learning and a strong wish to improve. This is true for all organisations. All research about organisational success improvement are that those organisations that are very open, that are actively seeking feedback, that look to compare themselves with the very best, are those which have the best chances of success in delivering their ambition. So again, I'd ask you to think about, do you know how you compare? Are you actively out there seeking feedback? I think the fact that you are all here today would suggest that you are, because the rest of the programme for the next 2 days really offers, there's some great stuff to learn and network. The third characteristic is about holding a powerful vision for change captured in practical planning. And I think these 2 things go hand in hand. The first about having a sense of where you want to take healthcare in your community, how you see that you will be able to spend to best effect to improve outcomes and reduce inequalities, the millions of pounds of money that you are stewards of, is really important, but that needs to be captured in the practical steps that will take you there. The fourth is about demonstrating inclusive leadership of communities and patients. And as I said at the start, one of the great strengths, I believe, of this new system is that we have that clinical leaders across the country have stepped up to lead change. And we see that one of the things that we're seeing as a result of that is a much stronger connection than perhaps we've always had in the past between, if you like, the place that clinicians hold in local communities, the conversations that can have round the Health and Wellbeing Board, and the day-to-day contact with patients to keep it really focused on what matters. The fifth is about having a culture of innovation balanced with managing risk, and I think this is always tricky in the public sector and in public funded organisation, because innovation always carries a level of risk. It always carries a risk of failure, but without innovation we wouldn't have had some of the great strides and advances that we've seen over the last century. So trying to get that balance is something that's going to be really important if we're going to manage to sustain the NHS. And then the final aspect is about being strong collaborators with other local commissioners around the needs of local communities. In the new system that's been created by the Health and Social Care Act, we have got multiple commissioners for the same population. And we know that research around the world, there's some interesting work that the World Economic Forum are doing about what's likely to create sustainable systems, that being able to get the maximum value out of, if you like, your public sector pound in Huddersfield or in Hull, that being able to do that will be critical to sustainability. And in this system, with NHS England as a direct commissioner, with local government, with CCGs, we need to really focus our efforts and build our capability in being able to work together to make that work. This is something that requires real focused effort and attention. So building from that, we are working on building a body of insight about what great looks like, looking at kind of the global research, doing some in-depth sort of deep dives into some of the best examples, looking at what we can learn from other sectors, bringing leading thinkers and practitioners together to describe what great would look like. And we're doing that, not ourselves, NHS England, but together with CCGs. And we're building a development framework which we will publish in July with under the auspices of what's the Commissioning Assembly Working Group around CCG development. And I'm really delighted that that's going to be jointly chaired both by John Buick, the Director of CCG Development, and Nadeem Fazlani from Liverpool CCG, and Graham Jackson from Aylesbury Vale CCG. We've had about 60 clinical commissioning group leaders come forward to be part of this. And I think this is something we absolutely want to be a joint piece of work. So what we will do in that development framework is we want to keep the kind of principle that this is something that needs to be locally determined. So it's up to you as a CCG about what's the development that you see that you need based on the insights you've had so far. But we need to create align the support that's on offer in all sorts of different parts of the system, and so that we can develop a kind of vibrant, innovative market of development support for CCGs. So we will use the development framework both as a way of setting out what great is, insight about what's needed, how we can develop learning networks to support different communities of interest, how we can capture best practice in some of the generic skills that all commissioners need, but we will also use it as the basis to leverage the money and resource that sits, as you can see here, from a lot of different parts of the system. So not just NHS England itself, but what happens with the local education training boards, where there are lots of money there. The NHS IQ, which is the NHS improvement body, are already on with a multi-million programme going out to as an offer to CCGs, the Leadership Academy and other partners. And we will look to develop in September an online directory of services so that you can share feedback, so that you can kind of begin to learn where do you get the best value for the money that you want to spend on development. So I will move on now to talk about the second area, which is commissioning support. And our ambition is that all NHS commissioners should have access to high-quality, affordable commissioning support. We really need to make sure we don't recreate PCTs. And for me, that's about making sure that clinical leadership in CCGs is free to focus on where clinicians add value and that they get absolutely the very best, most professional, streamlined support available. Later on today, and if I could give a plug to my colleague Bob Ricketts, who's running a session at 1 o'clock, we're launching the strategy for commissioning support services. And I think three things that I want to pull out from that. The first is, if you like, on the demand side. So how do we... A key strand of work will be about supporting CCGs to be the best possible customers. And we're launching today a mobile app for those of you who are into that kind of thing that will give you a directory of services about where you can get commissioning support, feedback. And this will be the kind of first phase, and then we'll learn from people's feedback and develop that. The second area on the supply side is about building the market of commissioning support. So number one, I mean, we've got 19 NHS commissioning support unit providers at scale across the country, and we will be putting a lot of attention and effort into developing those CSUs to become the best possible that they can be. But we're also today announcing a partnership with the voluntary sector about the offers that other parts not just the NHS can offer in supporting you in your job. And we know that in the voluntary sector, there's some great, very specialist expertise which people can draw on. And the third thing is about how do we make that the mechanisms, if you like, to enable both the development of the supply side and support CCGs in securing services. So we are launching today a consultation about the procurement of commissioning support. Under European law, in time you will have to go out to through procurement law, we'll have to go and secure commissioning support through an open competition process. So how can we make that good value, cheap and as effective as possible, so that we're not spending money on things that could otherwise be spent on patient care? The third area I wanted to talk about was incentives. So I think in all my time in the NHS, ever since I think tariff was invented, whenever you ask people what's the one thing that could be fixed, people always want to fix tariff, but it is a balloon that if you press it one way, it pops up somewhere else. But what we announced that we would do last winter was a review of the alignment of the incentives, rewards and sanctions that sit in the system. So we've begun some work, and again working with CCGs through an assembly working group on incentives around this, looking at some of the mechanics, the standard contract, the sequence, quality premium, and as you know, NHS England, we published a joint document with Monitor a few weeks ago about the national tariff design and pricing strategy. Now, what we're trying to do in that review is really make sure that we've got the best possible alignment. You can be the greatest organisation in the world, but if the tools and the rules don't support what you're trying to achieve, you will be limited as to how successful you can be. So we're trying to get that alignment right. And we will be publishing at the beginning of July a consultation document, and would welcome everybody's views on what can we do to get this alignment of the different incentives in the system to better oil the wheels for what you're trying to achieve in your local community. And then the final thing I want to talk about is relationships. And this may seem a little bit of a kind of softer dimension than talking about kind of the hard edge of how the money flows. There's some really interesting work done it must be about 5 years ago now, that looked at some health systems in England, two that had been successful in delivering great change, and two that had a go at trying but had not been successful. And this piece of work found that the really critical factor in the difference, the one thing that looked different, was the relationships between all the people, all the local leaders in those communities. And it's not something that's soft. It's a hard-edged thing that you have to work at. It's not about getting on with people. It's about creating an effective place where you can have dialogues, that you create shared purpose to drive change. And given what we know about the transformation that is needed in healthcare, this is going to be a really important area for all of us. So 2 things I wanted to mention that we're doing. The first is, a while ago now, we were approached by a group of CCG clinical leaders about how can we improve the national conversations between NHS England, or NHS Commissioning Board as it was, and CCGs, because our success is mutually dependent. We've got a shared goal of improving outcomes, tackling inequalities, and if we are going to achieve that, we need to work together. So we established the Assembly as a community of leaders, and with a focus on trying to begin to create some shared leadership of work, like CCG development, like incentives, as we go forward. And I think in the work that David Nicholson announced last week in developing a strategy for the health and care system, how do we work together with CCGs in doing that? And really to try and create a common voice on issues where, as the commissioners together, we need to have a shared view in order to carry more weight in all the different discussions that we have. So we've got some working groups on that. So I've mentioned a couple. Primary care, probably a really important one that's dear to many people's heart here. And we've also got a rapid reference groups, which have proved really, really effective. And I'm very grateful to any of you that are involved in that. I haven't met everybody who is, but it's a fantastically important and influential device whereby we can check out and get response back within 24 hours on issues. At the moment, we're talking about premature mortality. We've discussions about the A&E and the issues that have been in the media about A&E. And it's got both a clinical and a managerial dimension to it. So those have been fantastic. The second bit of work I wanted to mention was working with NHS clinical commissioners. And NHS clinical commissioners are designing a survey to test the views of CCGs of NHS England. And they've invited us to co-produce that with them. And what's great is we're not seeing this as like one survey. This is actually a device to help shape the relationships, the behaviours, the development for NHS England itself as an organisation. So we're taking this very seriously, and the results of that survey will be part of our corporate board reporting, and will be something that then we will act on. So I hope that gives you a quick sort of flavour of some of the work as we move from the setup phase to getting ourselves geared up to lead transformation. In kind of summary, really, we are therefore trying to create a great sector which is not just about quality today, but is about transformation tomorrow. I think it's really important that we hang on to these principles we've established about clinically led, localised commissioning. That can only happen if we have some professional, high-quality commissioning support, that we draw on what works, that we make sure that we keep CCGs. One of the things I think last week, I was listening to Bradford CCG talking about the difference it felt, Bradford City and Bradford District CCGs being a CCG from what they were before. And the number one thing they said was speed of decision making. And I think that's something that we need to make sure we hang on to. All of this needs the right levers and the right relationships, and that's something, as we take this work forward, that we'll also be paying attention to. So I'm happy to take questions if we have time, Amanda. I feel like I've run...
We've got about 2 minutes for questions. We've got a roving mic. Oh, it's on now. We've got a roving mic. We've got about 2 minutes for questions. So if anyone's got any questions for Ros, if you wave...
Ross, in your second slide, you mentioned about CCGs belonging to, CCGs have association with members, but you didn't define the members. Can you please define those? Because I would like to know who the members are.
Okay, so I guess there's a sort of legal answer and a feeling answer. So the legal answer is, in law, clinical commissioning groups are set up as membership organisations, with members being the holders of primary medical services contracts. So when people talk about the governing body, is that the governing body is not like a PCT board. The governing body oversees the effectiveness of CCG, and the constitution, each CCG's constitution, will have defined the role that the governing body will take. And that is different in different CCGs. But the members are the member practices. So it's the holders of primary medical services contracts. So that is the legal. The feeling definition is about what CCGs choose to create, about is this something owned by their communities, by your, by a wider group of professionals, your partners, than just that legal definition. But that's what I think is significantly different from any previous legal structure we've had in the NHS before.
I think
Thanks.
The feelings are better than the actual legal terms.
Yes.
Any more questions for Ros?
Thank you. I'm from Dorset CCG. We have an in-house CSU, and I was interested to hear you said that we might have to go out to tender for CSU services in the future under European law.
So, again, I'd probably give a legal and a feeling answer. So the legal answer is that if you have in-house services, you are not required to then tender. So that is the feeling answer. I would say is that I would just make sure that if I was in a CCG with a lot of in-house services, that you're confident that you're getting the best value from those services. And one of the things we'll talk about when we launch this the commissioning support strategy today is what kind of help or what support do you want to make sure you're getting best value out of in-house services, but you're not legally obliged to go out to tender.
Thank you.
Probably got time for one quick question if there's any more. Can't actually,
Yeah.
can't actually see.
No.
I was interested to see what you've said about the cooperation with the commissioning groups. However, what has happened is the prescribing advisors have been enforcing sulfonylurea as a second-line treatment in diabetes on all the GPs, and that is completely the cost savings, because the DVLA want everybody who is on sulfonylurea to have the blood sugar tested before he drives. So it means the cost savings straight away goes. Plus the treatment of hypoglycemia in secondary care will cost a lot of money, hundreds of thousands of pounds. So I think this policy has to be changed fully. As Professor Anthony Barnett says, the GPs should be allowed to prescribe a little more expensive medicine in the second line treatment diabetes to have cost savings in the long term. And this has also been shown by the Newcastle Group.
Thanks for that, I think. I don't know if it requires an answer from you, Ros.
Okay. All I say is that I don't know the detail of what's been nationally determined there from what you've said and what's a local issue, but I'm happy to pick it up after.
Okay, thank you all very much. Can I ask you all to thank Ros very much for coming along?